Good day. This is Dr.K Gireesh, physician, neurophysician and neurosurgeon, and this is the RNA series number 26. RNA series is nothing but the random questions in neurology and neurosurgery with answers by Dr. K Gireesh, and that's me. This is to benefit the practitioners of neurosciences, neurologists and neurosurgeons, and in the medical field for a lifelong learning and also for public awareness. In this series, the question I'm addressing is, what are the overall features of hemangioblastoma of the central nervous system? Hemangioblastomas typically occur in the young to middle-aged adults. They are estimated to account for only around 1 to 2.5% of the intracranial tumors, as pointed out by Ferosh as well as Murphy and others. There is a slight male predilection in adults, and the peak incidence is around 30 to 60 years of age. Sporadic cases make up approximately around 75 to 80%, with the remainder being found in patients with von Hippel-Lindau disease. The clinical presentations of these are headache, hydrocephalus, increase in the fluid in the brain, cerebellar dysfunctions, altered mental state, polycythemia. In a study done by Spiripolo, Murphy and others and published in the American Journal of Neurology in 1992, it showed the commonest picture is the headache, which is around 70%, hydrocephalus and symptoms of raised intracranial pressure in about 50% of patients, cerebellar dysfunction in 50 to 60% of patients, altered mental state in 10%, polycythemia due to increased erythropoietin production occurs in 20%. So, these are the clinical presentations of hemangioblastoma of the central nervous system. One study showed that in von Hippel-Lindau patients, the onset of symptoms usually coincide with the development of the cystic component, and that the solid cerebellar nodules were the most well tolerated. This is very important. It's a study done by the Moore et al. And others, and again published in American Journal of Neuroradiology in 2003. Well, the solid component and the cystic component, these are the two components for the hemangioblastoma. The pathology of hemangioblastoma is actually a capillary hemangioma, and despite the name with the suffix of blastoma, it is a low-grade tumor, WHO grade 1. The tumor is well circumscribed with a highly vascular mural nodule, almost always abutting the pile layer, and a peripheral cyst. So, the mural nodule and a peripheral cyst, there are similar contents to the blood plasma. Hence, it is suggested that the cystic component most likely arises by the exudation from the vascular component of the solid nodule. That is why in surgery, it is not only draining the fluid, but the mural nodule has got to be removed. Otherwise, the chances of recurrence are there. The location in the central nervous system, 87 to 97%. You find 95% of the cases in the posterior fossa, 85% in the cerebellar hemispheres, 10% in the cerebellar vermis, 5% in the medulla. Only rarely do they extend beyond the cerebellum into the CP angle. 5% is supratentorial. That is typically in and around the optic radiation, and this occurs only in patients with von Hippel-Lindau disease. Spinal, 3 to 13% of cases. The associated phenomenon or the diseases that are associated are pheochromocytoma, multiple renal cell carcinoma, von Hippel-Lindau disease, polycythemia. Now, these are some of the features that are associated with hemangioblastoma of the CNS. The radiographic features are, they are sharply demarcated homogeneous masses composed of a cyst with a non-enhancing walls, except for a mural nodule which enhances very well, and there will be a flow void that will be seen. The solid nodules are commonly abetting the pia mater. In the CT, the mural nodule is isodense to the brain, and on non-contrast CT scans with fluid density surrounding the cyst. After giving contrast, there will be intense homogeneous enhancement of the mural nodule. The cyst walls usually do not enhance, and calcification is not present in this hemangioblastoma. In MRI, the T1 weighted image hypo-intense to iso-intense the mural nodule, and the cyst is of CSF signal. With the gadolinium, there will be an enhancement of the mural nodule. And in T2 weighted image, hyper-intense of the mural nodule is seen, and flow voids can be seen due to the enlarged vessels may be evident at the periphery of the cyst. And fluid-filled cyst will be similar to that of the CSF. Angiography. Enlarged feeding arteries, often dilated draining veins are demonstrated with a dense tumor blush centrally. This is the angiographic picture. The treatment of this is just not aspirating the cyst and leaving it alone, but the removal in toto of the mural nodule. Otherwise, there is every chance that it can get recur. Now, usually this mural nodule is radio resistant. So, ideally, using a microscope, see that microsurgical, go around the mural nodule and excise it in toto. If it is in the periphery of the cerebellar hemisphere, it's very easy. But if it is towards nearer the brainstem, one has got to be extremely careful when you are excising the mural nodule. The differential diagnosis can be a brain metastasis, astrocytoma, ependymoma, vascular lesions, and medulloblastoma. These are the differential diagnoses. One has got to differentiate the two. Astrocytoma, brain metastasis. Although a single posterior fossa metastasis are uncommon, they are still the most common diagnosis if a patient is middle-aged or older. Astrocytoma, pilocytic astrocytoma, usually occurs in children. Ependymoma, vascular lesions, AVMs with subacute bleed, cavernoma with subacute bleed, subacute infarctions. Medulloblastoma, common in childhood, much more solid, restricted diffusion, small round blue cell tumors are seen. So these are some of the things which you have got to think of when you see a cerebellar hemangioblastoma. That's indeed the answer on what are the features of hemangioblastoma of the central nervous system, and this answer is in brief. Thank you very much.